count report. Then we are talking about the test regarding the platelet. And then we are talking about the other parameter. It is WBC or white cell count along with the differential count. These are the three main parameters that is going to be present for the seen that can be seen in a whole blood count report, right? So these three parameters are very helpful for a clinician to come on a conclusion regarding the patient condition, right? Whether what is the type of disease, or except regarding the disease, even in a mild fever up to the cancer, the patients are estimating the full blood count.
Recording in progress.
Right. Estimating full count report or estimated of a full blood count is very important in each and every type of disease. As an example, if the patient is suffering from a fever, we order full blood count. If the patient is suffering from a stomach ache, at that point, we along with the urine FR or UFR, we request or the clinician request a full blood count estimation, right?
Excuse me, slides are not shared.
So someone has been stopped that time. Is it okay now?
Now okay.
Right.
Yes, yes.
Right. Sorry about that. Right. When you are regarding what is the type of disease, what is the type of the condition patient is suffering, without regarding the condition, each and every time the full blood count is a important test. Why is it important? Because where is the disease in the body? It may be in the stomach, it may be in the head, it may be in the chest, or each and every place is representing this full blood count. Why? Any change occur in the body is represented by the body fluid of blood, because the blood is going to be travel each and every way, right? That is the importance of the disease, importance of the full blood count. Apart from that, my topic is routine hematological investigation, right? When we are talking about the routine hematological investigation, the main one is the full blood count. When it comes on to the full blood count or the FBC, sometimes some people used to say it as C.B.C or complete blood count. There are parameters related to red blood cells. The parameters related to red blood cells are hemoglobin or HB, PCV or HCT, then the RBC count. So what we want to do, what we want to know, with the use of modern analyzer, instead of PCV, instead of pixel volume, we use a term known as hematocrit or the HCT. The difference between the pixel volume and the hematocrit is, in PCV, we manually estimate by centrifuging a blood sample for a certain time of period. The time is going to be differ from the method that we are going to be used. If it is a microhematocrit method, only 5 minutes we are using the centrifugation time. If you are using the other technique, we have to centrifuge the sample about 30 minutes. So when we are estimating it manually, we name it as packed cell volume, right? But in the automated analyzer, it is going to be named as hematocrit or the HCT. HCT means the total volume of red cells going to be present in a certain amount of blood. It means if we are take 1 liter of blood, what is the percentage of red cells going to be present in this blood volume is going to be named as hematocrit. The difference between these two is packed cell volume and the HCT is the calculated one where we are using in automated full blood count analyzer. So if I remember just about the principle of the automated analyzer, they are measuring the red cells by impedance technology, right? Impedance technology means once a cell is going to be flow through a flow cell, the pulse is going to be measured. Once one cell is going to be past the flow cell, it count one cell. When it goes the second cell, it is going to be counted as the second cell. When it passes the flow cell, third one, it is going to be counted as the third cell. With that count, they are going to be count the number of cells. According to the pulse generated by the cell, according to the height of the pulse, they measure the volume of the cells. Right? Finally, the total volume, normally, according to the machine, it is going to be varied at the time of count from 4,000 to 8,000 of cells. Suppose your machine is going to be generated report within 1 minute. Within this 1 minute, some machines are going to be count about 4,000 cells. Some machines going to be count about 8,000 cells. Right? They calculate the total volume of these 8,000 cells. And finally, divide the total volume by the number of cells and average cells or the mean cell volume of the average cell size is going to be given as the mean cell volume. It is going to be named as MCV. Finally, again the cell is going to be multiplied, or the MCV is going to be multiplied by the count, total count, and it is going to be given as the HCT or the hematocrit. There is a small difference between the packed cell volume and the hematocrit. What is that? Why is that? In the packed cell volume, there are among the cells, the plasma are going to be get trapped. When we are estimated the PC or the packed cell volume by manually, among these cells, some amount of plasma are going to be get trapped. But when we are going to be talk about the HCT, no plasma trapping is there. Plasma is not going to be trapped in HCT because we are going to be count purely cells only. Because of that, when we are comparing PCV and HCT, HCT is somewhat slightly lesser than the calculated PCV. You have to remember that HCT is going to be somewhat lesser or slightly low than the estimated PCV or manual PCV, right? I want to say that these in some machines, as I expressed earlier, some machines are going to be calculated HCT directly. Some machines are going to be, some machines are going to be estimated HCT directly. As I mentioned, they summate the total volume of the cells, right? I told you that about 4,000 to 8,000 cells are they are going to be count. They summate the total volume of the cells and give it as the HCT. But in some machines, they average the cell and give the PCV, right? Some machines give HCT as estimated parameter. Some machines give MCV as the estimated parameter. It is going to be differ according to the machines, right? So because of that, in some machines, they estimated hemoglobin count, hemoglobin value, PCV or HCT, and RBC. With the use of these parameters, they are going to be calculated the following parameters: MCV, MCH, MCHC, and RBW. MCV means mean cell volume or the average volume of a cell. Mean cell volume means average volume of a cells. If you want to calculate the mean cell volume by manually, what we have to do, we have to divide the PCV by hemoglobin count. Sorry, we have to divide PCV by the RBC count and multiply by multiply it by 10, and we can calculate the MCV as femtoliters. Divide PCV by RBC and multiply by 10, and it gives the average volume of a cell in femtoliter. Normally, the normal cell size or the average MCV or the normal MCVs lie in between 82 to 102 femtoliters. 82 to 102 femtoliters. By looking at a full blood count parameter, or by looking at a full blood count report, we can say whether this patient is having normal size cells or normocytes, or the patient is having the small cells or the microcytes, or the patient is having bigger cells or the macrocytes. If it is going to be, if the MCV is going to be lie in between 82 to 102 femtoliters, we say the patient is having normal size cells or the normocytes. If it is going to be go beyond 102, normally in some conditions such as the megaloblastic anemia, it is go over 110 femtoliters. It means the cells are going to be somewhat bigger than the normal cells. At that time that we say the patient is having the macrocytes or the big cells. But in sometimes the patient is having, or the patient's MCV or the mean cell volume is going to be less than 82 femtoliters. Sometimes it may be go lesser than around 50 to 60 femtoliters. At that time we say they are going to be named as what? They are going to be named as what? If the MCV is going to be less than 82 femtoliter, anyone? Right, I'll say it is, if it is going to be less 70 less than 82 femtoliters, we are going to be named it as microcyte, right? Likewise, we can calculate the average size of the cells but manually, as well as the machines calculate in the same way the MCV or the size of the cell. Then we can calculate the average hemoglobin concentration in a cell or mean cell hemoglobin, MCH. MCH mean cell hemoglobin. It is going to be calculated by dividing hemoglobin level by the RBC count and multiply it by 10. Divide hemoglobin by the RBC count and multiply it by 10, and the unit is going to be given as the picogram. Right? It says the average amount of hemoglobin going to be present in a cell. If it is going to be in between 27 to 32, the normal range. If the MCH is going to be in between 27 to 32, we name the patient is having normal amount of hemoglobin in the red cells, and we name those type of red cells are normochromous cells. If it is going to be get lower than the 27, we name them as, or we identify those cells as the hypochromic cells. If the cells are going to be having more than 32 picogram of hemoglobin, or the MCH is going to be over 32, we name them as the hyperchromic cells. Actually, it is very rare the hypochromasia or the hypochromic cells are going to be present in the circulation, not apart from some rare conditions of the disease. But frequently we can see the low amount of hemoglobin, low amount of hemoglobin in red cells or the hypochromic cells are going to be more prominent in most of the disease. And the next parameter is MCHC, mean cell hemoglobin concentration. This is going to be named as the average hemoglobin in 1 unit of blood. The average hemoglobin concentration in 1 unit of blood. This is going to be calculated by dividing hemoglobin level with the PCV or HCT. By dividing hemoglobin concentration with PCV and multiply it by 100. The unit of the MCHC is gram per deciliter. Normally, the normal range is going to be in between 32 to 35. Normally, the amount of in normal patient, the MCHC is going to be lie in between 32 to 35. Right? If it is going to be having in between 30 to 35, the patient is having normal amount of blood or normal amount of hemoglobin concentration related to the volume. Right? If the patient is having low amount, less than 32 gram per deciliter of MCHC, it says the patient is having low amount of hemoglobin compared to the volume of blood. If the MCHC is going to be low, it says the patient is having low amount of hemoglobin concentration comparing to the volume of blood. If it is going to be over 35, it is going to be having, it says the patient is having higher amount of hemoglobin compared to the volume of blood, right? Then the last one is RDW. This is going to be appear in different formats. It may be RDW, SDRDW. It is going to be CVRDW, likewise in different formats of in the different type of reports. But the main feature of this RDW is red cell distribution V. This means the range of cells going to be appear in the circulation of the patient, or in the sample of blood, what is the range of red cells that are going to be appear? If I say, if the patient is having almost all the cells are going to be microcytes, if the patient is saying almost all the cells are going to be microcytes, there is no big range. It is going to be lying in a narrow range, right? If the patient is saying almost all the cells are going to be normal cells or the normocytes, they are also no a big range. RDW is going to be normal. But suppose a patient who is a patient who has transfused blood, who is having severe iron deficiency anemia, to a patient who has having severe iron deficiency anemia, we transfuse blood. In that situation, the patient is having microcytes as well as the normocytes. In that situation, the patient is having microcytes as well as normocytes. At that time, there are a different range or two populations can be seen in the patient circulation. It means the patient red cell distribution is going to be somewhat bigger, right? The patient red cell distribution, right? When we think about කිව්වොත් අපි microcytes තියනවා නම් එතන තියෙන්නේ එකම range එකේ cells. Nomocytes විතරක් නම් තියෙන්නේ එතන තියෙන්නේ එකම range එකේ cells. එතෙන්දී RDW is going to be normal. හැබැයි population දෙකක් හරි even in iron deficiency anemia, it is having different size of cells. At that time, the RDW is going to be bigger. Range is going to be bigger. We name that condition the RDW is going to be much bigger than the normal condition. Right? If the RDW is going to be bigger, we can say the patient is having different type of cells going to be present in the patient circulation. Right? So when we are talking about the RBC parameters, there are estimated parameters as well as calculated parameters. In the full blood count report, there are red cell estimated parameters as well as calculated parameters. Normally, HB, PC, RBC are going to be named as the estimated parameters, and MCV, MCH, MCHC, and RDW are going to be expressed as the calculated parameter. But there is a problem with these two. In some machines, HCT are going to be calculated and MC is going to be estimated. Right? In some machines, vice versa. සමහර ඒවාගේ PCV එක HCT එක calculate කරලා MCV එක direct measurement එකක් විදියට ගන්නවා. සමහර machine වල PCV එක එහෙම නැත්නම් HCT එක estimate කරලා MCV එක calculate කරලා ගන්නවා. Right? These are the red cell parameters that is going to be present in full blood count estimation. If you saw this, if you have a look on this report, see here the RBC count is there, hemoglobin level is there, HCT is there, then MCV is there, and MCH there, MCHC is there, and RDWC coefficient of variation is there, 11.7. Normally RDW is going to be lying between 10 to 15, right? That is the normal RDW. If it is going to be go beyond the 15 and go lesser than the 10, that is, or the range is going to be get bigger, it means the patient is having higher deviation of red cells parameters in that patient circulation, right? Any question regarding the red cell parameters before I move on to the next one?
I have a question regarding this.
Yes.
So, in case of bacteremia and septic condition, what are the parameters to be concerned?
I didn't got your question again, right? In condition of septicemia, yes.
And bacteremia, how it vary, I mean, regarding those parameters.
Right.
At once we can jot down the parameters of abnormalities, with abnormalities.
You are talking about the red cell parameters.
Yes.
The red cell, right? In bacteremia and the septicemia, right? Suppose if the patient is in bacteremia and septicemic condition, what is going to be happen? The patient red cell sometimes may get ruptured, or the due to the toxic condition or due to the bacterial action, the patient red cell get maybe damaged, or hemolysis can be occur, or the fragmented red cells can be happen. So at that point, what is going to be happen? The patient, these parameters, HB is going to be make it get low, PC and PC may be going to be get low, as well as RBC going to be make it low. It means the patient's totally going to be get anemic condition, right? Right. In that condition, what is going to be happen? The MCV, what can be happen? If the PCV is going to be get low, according to the calculation, MCV also going to be get low, right? MCH going to be get low. It means suppose it look like an iron deficiency anemia, not much to the level of iron deficiency anemia, but sometime it is going to be look like iron deficiency anemic condition, right? I will come on to that point, how we can differentiate these type of disease. We can't differentiate it by looking at a full blood count report. We have to take action to differentiate it. But RDW in this condition, it is going to be get higher. Red cell distribution width is going to be higher in that condition. Why is that? Some cells are going to be get lysed, or some cells are going to be get fragmented, while the normal cells are going to be present in this patient circulation. It means the patient is having normal cells as well as abnormal cells, fragmented cells. At that time, the range of cells going to be present in the patient circulation is going to be higher. Because of that, RDW is going to be get higher.
Right. Thank you very much.
Right.
Another question, shall I ask?
Yes, okay.
So what about dimorphic blood picture? What will be the distribution with of RDW and other parameters?
Sorry, can you ask it again for me?
dimorphic blood picture. Now, in
Yes.
case of, now there are some iron treatment and other things.
Yes, I told it earlier.
Mm.
In dimorphism or in dimorphic films, or when we are treated for a patient who having anemia or iron deficiency anemia, the patient is going to be having dimorphism. At that
Mm.
time also the RDW is going to be get higher because it is having different type of cells. Because of that, the RDW is going to be get higher at that time.
Right, thank you.
Any questions? So one person has been asked that how to calculate color index. What do you mean by the color index?
I think there is a formula in case of red cell parameters. That would be the question he asked. Color index and CI. Particular formula, as I remember.
Yes, I don't got that point, right? So if I search it and on the next day I'll mention about that, right?
Okay.
Apart from that, any questions? Right, okay. I'll move on to the next one. Right. When we are regarding the other parameters, right, the next one is the platelet. In the platelet, we count the platelet number, right? With the same mechanism or with the same method that we are used to count the red cells, we count the number of platelet going to be present in the patient using the impedance technology, right? So along with the platelet count, the mean platelet volume as mean cell volume, the mean platelet volume is going to be measured as well as the platelet distribution width as RDW. Along with the platelet count, the platelet distribution width is going to be estimated by the automated analyzer. But once we are doing it is manually, these mean platelet volume as well as the PDW, the platelet distribution width is not going to be appear in the manual estimated full blood count. But with the modern technology, mean platelet volume as well as PDW is going to be there, right? Normally, when we are looking up the platelet count, we look for the number of the platelet, whether it is going to be lie in between 150 to 450,000 per microliter, or it is lesser than 150, or it is go over than 450,000 per microliter, right? If it is going to be higher or lesser, we can identify it is going to be whether mild decrease, moderate decrease, or marked decrease, as well as we can identify in the higher condition whether it is mild increase, moderate increase, or marked increase. But the importance of normally it is we think that there is no importance of the mean platelet volume and the platelet distribution width. Yes, in normal situation or in the normal condition of the patient, there is a no actually there is no need of the MPV and the PDW. But in conditions such as the dengue fever, as well as in the conditions such as the abnormal platelet number or the count, we have to think about the mean platelet volume and the platelet distribution. Because in the case of dengue fever and in some viral condition, the patient is having lesser number of platelet count. Platelet count is going to be less than 150. But the mean platelet volume is going to be somewhat bigger. Mean platelet volume is going to be somewhat bigger because in the dengue fever, or when the fever is going to be get recovered, or the patient is when the patient is going to be get recovered, the patient is going to be having the giant platelet, right? In the recovery phase of the dengue fever, the patient is going to be demonstrate with the giant platelet. At that time, the MPV or the mean platelet volume is going to be get high than the normal range. So It is important in such case, if the patient is having the MPV is going to be high, it means the patient is having the patient is in the recovery phase. As well as in that case, the patient is having normal size of platelet as well as larger size of platelet. As in the red cell parameter, in this situation also, the patient is having the dimorphism in the platelet. Here, again, as RDW, the patient PDW is going to be get higher than the normal. It says the patient is having dimorphic platelet in the picture. That is in a condition such as dengue fever. Suppose in some situation, sometimes the platelet is going to be get aggregate. Instead of one platelet, sometimes there may be two platelets are going to be get aggregate. Right? So these platelets are going to be sometimes going to be calculated as RBC because in the automated analyzers, the red cells and the platelets are going to be get counted in the same bar or the same counting chamber. Right? They differentiate the platelet and the RBC according to their volume. Right? If I say the cells in between 36 to 360 micrometer going to be calculated as red cells. The cells in between 2 to 26 micrometer are going to be calculated as platelet. Suppose the patient is having the platelet aggregation phenomenon or due to maybe ETA, maybe the patient own condition or the autoimmune condition, platelet are going to be get aggregate. What is going to be happen? Instead of normal size platelet, two platelets are going to be get added here, and the mean platelet volume is going to be get increased, right? So at that time, we know the patient is having platelet clumps or the patient is having some abnormal phenomenon in the platelet count. We can justify or we can see that phenomenon. If the MPV is going to be get abnormally high, we have to correct in a later stage. I'll say where it is going to be corrected. So how it can be corrected. As well as suppose, all right. Before I go to this, I want to say normally there is a correlation of red cell parameter, free red cell parameter. Normally, 3 times of RBC is going to be equal to hemoglobin concentration. And 3 times of hemoglobin concentration is going to be equal to packed cell volume or the HCT. Right? I'll say it again. Right? If you are working in an hematology laboratory, you know this. But the people who are not working in hematology laboratory, I think they are not going to be aware of this one. Normally, 3 times of RBC count is approximately equal to the hemoglobin concentration. Again, the 3 times of hemoglobin concentration is going to be approximately equal to the packed cell volume, right? So, we name it as the rule used in the automated analyzer. If this correlation is not going to be appear in your report, if this correlation is not going to be appear in your report, it may be a pathological condition. It may be a error in your counting machine. Or it may be a problem with your sample. Right? At that time, we have to look at the mean platelet volume. As an example, if you are estimating a blood count of a patient with anemia, at that time, most of the cells are going to be smaller than the normal cell or microcytes. These microcytes may be calculated as platelet. At that time, the RBC count is going to be get low and the platelet count going to be get erroneously high. At the same time, the mean platelet volume is going to be get increased. Why? instead of platelet, they are going to be count the microcyte as the platelet. Instead of platelet, they are going to be count microcytes as the platelet. It means the cells bigger than the platelet are also counted as platelet. Platelet වලට වඩා ලොකු cells උත් ඒ කියන්නේ microcytes උත් platelet විදිහට count කරලා තියෙනවා. Now what is going to be happen? The average volume of these cells are going to be get increased. At that time, the MPV is going to be increased as well as the PDW is going to be get, right? So by looking at those parameters, we can say there is some abnormality in the patient cells, or there may be some problem with this patient. We have to correct it by in the next step. So I am already always saying in the next step, we'll see what is the next step, right? So these are the parameters regarding the platelet count is there, and MPV is there, and the PDW is going to be there. But other than these, in some modern new parameters, different types of many other parameters can be seen, but the important parameters going to be present in the platelet count or the platelet number and main platelet volume as well as platelet distribution. Right? Any question regarding that?
I have a question regarding this. Right?
Yes.
So sometimes in case of hematological analysis,
Yes.
right, there may have chance to contamination of fungal and others. So
Fungus,
also, yes,
fungus going to
even
be
give erroneous in case of platelet count, right?
yes, yes.
In the even immunocompromised patient where we can find fungemia, right, like that condition. Sometimes it may mislead regarding platelet count because now when
Erroneously increased platelet count
yes,
can be demonstrated.
because
Right. We have to correct that, no?
yes, we had faced such case studies. That's why
Many,
I'm
yes,
very, very
right.
right.
So I also have faced same problem, right? I time to time I say there is a corrective phase in this full blood count estimation. I may come on to that I'll give answer. I will give you answer at that point. Okay, right? So there is a corrective phase in the full blood count report. In after discussing of the WBC, I may come on to that point and I'll describe what is the method. Okay.
Okay.
Right.
Thank you.
Right. Any questions?
Excuse me, Aya, are there any relationship between the PLCR value and a low platelet count?
PLCR value and the low platelet count, right?
Yes.
What is the meaning of PLCR value? So I can answer it if you know that. Right, there is a relationship. Actually, there is a relationship, right? So, right, the long-term PLCR, we want to know what is the meaning of that, right? I'll say it again in the later stage, right?
Thank you.
Right. Apart from that, right. The other important one is the other important parameter of the full blood count estimation is the white cell count, right? So along with the white cell count, we do the differential count, right? In the white cell count, it is going to be again, the total white cell count is going to be total white cell count is going to be measured using the impedance technology. But in the differential count, earlier it is going to be measured with the VCS technology or volume, conductivity, and also the scatter light or the light scattering, right? So it is the principle of the full blood count estimated analyzer. I am not going to be describe more about that, but I want to say using the VCS technology, they are going to be measuring the 3D picture of the cell. Using this 3D picture, they are going to be put these cells into different type of categories. But with the introduction of the fluorescent technology, this has been enhanced into more modern parameters, right? Earlier we do only the 5 categories of the cells, or neutrophil, lymphocyte, eosinophils, basophils, and the eosinophils, right? And the monocytes. These are the main 5 parameters. But nowadays, even the immature cells or even the abnormal cells are going to be found by the machine using the fluorescent technology. What is going to be doing there? They spray a dye or the fluorescent dye to the cells and estimate the elimination of these dye along with the VCS technology. Impedance technology is there, VCS technology there. Along with that, the fluorescent technology also going to be appear in those type of machines. So with that, they are going to be give more accurate results, right? Not only the differential count, in some cases, they are going to be diagnosed the parasitic stage such as the malaria. Even the malarial presence are going to be present in the diagrams or the scattergrams in the machines with this fluorescent dye technology, right? So importance of this total WBC and DC parameter, most of the condition white cell count going to be get higher, lesser, or normal, right? So most of the time, as an example in bacteremia, the patient's total white cell count going to be get increased. In leukemic condition, the patient total white count is going to be get increased. This increase may be either mild, may be moderate, or may be marked increase. In the same way, in some type of immunocompromised patient, the white cell count going to be get decreased. Even in some leukemic condition, the patient white cell count going to be get decreased. In viral conditions, the patient white cell count going to be get decreased, right? So at that time, the count may be get decreased in mild decrease, moderate decrease, or marked decrease. If it is going to be go beyond 1000, it is going to be named as marked decrease of white cell, right? So not only with use of the total white cell count, we can come on to a conclusion. Along with that, we want to know the different count or the differential count. So the differential count, we want to see the patient is having higher number of neutrophil or higher number of lymphocytes, or the patient is having the higher number of eosinophil. In parasitic condition, the patient is having higher number of eosinophil. In some kind of bacterial condition, the patient is having higher number of neutrophil. In some condition, the patient is having normal number of WBC is going to be get normal, but the patient lymphocyte count is going to be get increased. In some condition, the WBC count is going to be get low, in between 3000, 2000, but the patient lymphocyte count is going to be get increased. We name that we can identify at that time the patient may be having a viral infection. It helps the clinician to detect whether the patient is having the diagnosed area, in whether the patient is having the bacterial infection or the viral infection or the parasitic infection, or the patient count is going to be related to their diagnosis. If the clinician suspect the patient is in a bacterial condition, if the patient report is going to be show higher number of white cells along with the increase of neutrophils, the clinician suspicious is going to be confirmed, right? It is important in that way the patient to manage the patient condition along with the WBC and the differential count, right? Not only that, the immature granulocytes are going to be measured in these automated analyzer, as well as they are going to be count the NRBC. Even NRBC going to be differentiated with the automated analyzer, right? If they calculated and give the NRBC, we can correct the WBC count using that NRBC percentage, right? So suppose in some condition, such as the thalassemia, they are going to be give erroneously high results of WBC, right? They are going to be give erroneously high results of WBC due to the presence of the NRBC in the patient circulation, right? So at that time, we have to correct the WBC count. So one time we got a patient who is having the thalassemia, 60,000 of WBC count. But actually, when we see the manually or when we are going to be correct the WBC count, the patient is not going to be having even 15,000. Almost other 45,000 is going to be the NRBC or the nucleated red blood cells. Right? It is important to see the presence of the NRBC in the circulation. Modern machines, they are going to be give even the NRBC count along with the differential count. Right? These are the parameters of the WBC, right? After detecting these parameters, the machines is going to be give the flags. The flag means the abnormalities regarding the full blood count report. They say in a separate box of the machine, they are going to be give the flags. Sometimes they show the patient is having higher number of WBC. They say the patient is having leukocytosis. Sometimes they may say the patient is having leukopenia, low number of white cells. Sometimes they say the patient is having thrombocytosis or thrombocytopenia. Sometimes they show the patient is having platelet clumps, right? So these are the situations where the patient is going to be having the machine is going to be give us the flags, right? So at that time, what we have to do, right? Before we go to do that, any problem regarding the WBC parameters? Right. Now see, when we get a full blood count from automated analyzer, we can see a report like this. Right. So I must say in this full blood count report, there is a small, right, there is a problem with this full blood count report. I told you there should be a relationship between RBC, hemoglobin and HC, right? See here, the RBC count is 3.89. It is going to be around, almost around 4, right? The hemoglobin level is going to be 12.7. It is almost equal to the 3 times of RBC, approximately. But when it come on to the HCT, if we multiply 12.7 by 3, it is going to be around 38. But here the HCT or the PC is going to be 34.4. Right? So what is going to be there? The ratio is not going to be there, and also it has been indicated by the stammer. So these type of abnormalities, or sometimes that one person asked from me, if there is a problem regarding the platelet count, how we can correct it? Or if there is a problem regarding the WBC, how we can correct it, right? So how we can correct these? What we have to do, if we observe any abnormality of the report, first thing, what we have to do, we have to observe the sample. First thing, the important one, most of the people are not going to be this in most of the laboratory. මේ පළවෙනි step එක කරනවා. What, right? Most of the people are going to be do the first step, observe the sample. Then compare with the request form. we have to compare the sample with the request form, whether the sample is going to be tally with the patient name, BHT, and the collecting date, and all the other things, right? If the sample is not going to be plotted, and if the patient sample is going to be tally with the request form, and then we have to compare, or we have to tally with the patient history. Report has to be tally with the patient history. And if all of these are going to be okay, what we have to do, we have to draw a blood film and stain the blood film and observe the blood film, right? We have to draw a blood film and stain it with the Leishman stain and observe the blood, right? So can you ask the question earlier that someone asked, I can't remember the name actually. So right, one person asked from me, if the sample has been contaminated with the fungus, how we are going to correct that? So at that time, we know if the sample is going to be contaminated with the fungus, the patient platelet count going to be get increased. Actually, I told you I have faced such a problem. At that time, the patient is going to be not having the higher platelet count. The patient was having the higher number of white cell count along with the lymphocyte count. So the staff nurse who is got pregnant, do the full blood count, and the count is going to be more than 30,000 along with the higher number of lymphocytes. At once we are going to be suspect the patient is in the leukemic condition, because the 33,000 along with the lymphocyte, it is going to be unlikely to be in a pregnant woman. So what we have been done, we asked the breast sample. Actually, we didn't draw blood film. We asked the breast sample and do the count. At that time, it is going to be get okay. The total WBC is going to be around 12,000 and higher number of neutrophils are there. It is going to be tally with the patient history. But we was having a problem. Why such a number of count is going to be there? We draw blood film and observe there, and the film is all lot of filled with the candida. The film is going to be filled with candida. What was happened at that time? We are going to be reuse the EDTA bottles, EDTA tubes. At the cap of the function side, the fungus grow is there. These fungus are going to be contaminated with the blood, and it is going to be count as the white cells, and it is going to be give erroneous white cell count. Those fungus cells are going to be count as the lymphocyte. That's why the patient is going to be having higher number of WBC and higher number of lymphocytes. So by looking at a blood film in an abnormal situation, we can correct most of the errors that is going to be occurring issue in a full blood count. Before issuing an abnormal report, where you can draw blood film, do it. As much as possible, draw blood film and observe it, right? So even the patient is having low number of platelet, if your report is not going to be tally with the condition or the patient history, draw blood film and see. Even in the situation where the patient is going to be given abnormal red cell parameters, draw blood film and observe the blood film, right? I must kindly ask from you, right? Most of the time, we have been lose our duty or our responsibility by without doing this. As an MLT, you may be able to observe a blood film and report what you can see in the full blood count. So if you are going to see the hypochromic microcystic cells, whether they are not going to be as a blood picture or anything, you write it. The film shows hypochromic microcystic cell. Platelet clumps are going to be seen, right? and the abnormal platelet, giant platelets are going to be seen. High WBC is going to be 6 seen along with the toxic granulation. Or the high WBC count is going to be seen with a mild left shift. Likewise, draw a blood film and see. And at that time, you can correct most of the errors going to be occurred in an issue in a full blood count report. Right. So that is the situation where we can, or that are the parameters that is going to be seen in a full blood count report. So if anyone asks from you, what are the parameters that is going to be present in a full blood count parameter, you have to write all of these, right? But I think, I don't know, right? According to your curriculum and other things, I think they are not going to be asked what are the parameters going to be present in the full blood count report. But this one is important. If you have got any abnormal results, what are the further steps that you are going to be taken? It is very important as NL, right? Any question? Right. One person asked from me a question regarding the P platelet LCR or PLCR, and I can't remember actually the question. Can you ask it again from me?
When there is a low platelet count, blood
Yes.
smear, sometimes blood smear contains giant platelet now.
Yes.
At that point, PSR value gets high. I am
Yes.
asking, are there any relation between the PLCR and the low platelet value? Is it related to giant platelet?
Low platelet count and the PLCR value, right? Right. Sometime there may be, if actually the giant platelet are going to be present, right? The relationship may be there if the giant platelet are going to be actually present in the patient blood film. But in some condition which I have been mentioned, the aggregation of platelet, it is not going to be there. If actual giant platelet present, the relationship is there. But if the giant platelet aggregation is going to be there, the relationship is not going to be there, right?
Thank you.
Right. The question who asked about that fungal infection or the fungal contamination, I think you got the answer from me.
Yes, thank you.
Right.
Shall I ask question again?
Yes. Okay.
So in case of hemodiluted sample, partially or fully, right?
Yes.
So when we count, when we doing our duty, so what would be the erroneous? I mean, sometimes I mean, this is not throughout regarding hemodilution, but sometimes there may be have a chance partially. Actually, at
Partially.
times we can't identify it, right?
Yes. Sample is going to
Sometimes
be partially hemolyzed. Right.
yeah,
So think about the
not hemolysis, hemodiluted.
hemodiluted.
Yes. Sometimes they use IV lines and other.
Yes. Yes. Right. Right. So at that time, what is going to be normally, if it is going to be hemodilution, or you say that the blood sample has been aspirated from a IV line arm, right? At that time, what is going to be happen? The patient, all the cell parameters are going to be get low, right? We can have a report of pancytopenia, WBC low, RBC low, HB, and also the platelet count is going to be get low. So actually, it is, you say that partially hemodiluted, not fully diluted. We cannot observe, but the total parameter, total three cell lines are going to be get low. At that time, what you have to do, again, draw blood film and observe. When you are going to be draw the blood film, you can feel that this is going to be get hemodiluted. Blood film එක අඳිනකොටම තේරෙනවානේ මේක dilute වෙලා කියලා. And anyway, observe the blood film and ask for fresh blood film and redo the testing.
What are the notification in blood picture?
In the full blood count, right? HB low,
No,
WBC.
I'm asking regarding the blood picture.
Right. So in the observation of the blood film, you can see the red cells are going to be here and there. not going to be in the packed cells, right? Can happy lesson blood film it is going to be, the reds are going to be spread out in different places, right? And the platelet are going to be very minimum. Small amount of platelet are going to that. So the parameters looking at the full blood count, we can see even in that film, right? So it is going to be the main feature. At one point, you can see the cells are going to be get detached in different. The difference between two cells are going to be get much bigger, right? It shows that the patient is having the hemodilution.
Right. Okay. Staining property, what would be?
Right. Sometimes the background stain can be happen. Other than that, the red cells are going to be get stain in pale color. White cells and the platelets are not going to be get much affected, but the red cells are going to be get fade in color. If you are using the same type, the cells are going to be get faded.
Right. Thank you.
Any questions?
Sometimes we got EDT-induced thrombocytopenia.
Yeah.
How can we detect it without observed blood film? Are there any methods?
Yes, EDTA induced thrombocytopenia without looking the blood film, right? It is a very difficult condition without looking the blood film. It is difficult to see, but it shows in the full blood count report, your total platelet count is going to be get low, but the RBC count going to be get high. And the relationship between the RBC and HB is going to be get not there. I told that it should be 3 times of RBC should be in the hemoglobin. That relationship is not there, and erroneously RBC count going to be get high, and the red cell platelet count is going to be get low. We have to suspect that there may be a platelet clump. There are going to be platelet clumps. Maybe EDTA induced, so sometime the any other condition, platelet clumps are going to be get there.
Right. Thank you, sir.
Right. Can you explain importance of absolute count? Right. Which one absolute count? Absolute differential count. Right, in the chat book there is answer. Can you explain importance of absolute count? I think you are asking from the absolute WBC count.
Yes, sir.
Right, okay. Right. So the importance of the absolute count is, suppose you have a full blood count of a baby. The count is going to be 10,000. And the patient lymphocyte count is going to be 70, right? But you don't know whether this patient is having, whether the patient is disease 1 or something. At that time, the importance of the absolute count is, in the pediatric one, the absolute count, absolute white cell count is going to be lie between some range. But in some condition, if the patient is an adult one, if the patient WBC count is going to be 10,000, patient count is normal. But along with that, the lymphocyte count is going to be around 50, not 70. At that time, what is going to be happen? The patient absolute lymphocyte count is going to be get higher. It is the disease condition. But in pediatric situation, it is not going to be a disease condition. According to the patient condition, the importance of the absolute count is going to be important to detect whether the patient is having a disease condition or not, right? It is similar to the differential count. The absolute count is important to detect the which type of disease is going to be having the patient. Whether it is a bacterial infection, whether it is a parasitic infection or the viral infection, or whether it is going to be a malignant state, with the use of absolute count, it can be differentiated. That is the importance of the absolute.
Thank you, sir.
What else? Right. So in our strain blood film, what you have to see, you have to observe the red cell for morphology. You have to observe the red cell morphologies and see whether the cells are going to be normocytic, microcytic, and macrocytic. And you have to see the shape of the cells, whether they are going to be round, oval, or the spherical or elongated, such as the pencil cells, or whether they are going to be have the biconcave shape, such as the target cells. And you can write what are the cells are going to be present in the blood film. And also you have to observe in the blood film the HB concentration or the hemoglobin concentration, whether the red cells are going to be normochromic, hyperchromic, or hyperchromic, right? So regarding the white cells, you have to observe about the number. You have to observe about the number, whether it is going to be normal, decrease, or increase. In the case of increase and decrease, you have to mention about the mild, moderate, or marked increase or decrease. And then observe the morphology and look for the more immature cells. And also observe for the inclusions and do the differential count. Manual differential count. Check whether it is going to be tally with your automated analyzer one, right? So in differential count, see the total number and the cell morphology regarding whether they are going to be normal or the presence of immature cells and presence of inclusions, as well as the differential count. Inclusions such as the toxic granules and the vacuoles and the other things, hypersegmentation, whether cells are going to be get hypersegmented, right? When it come onto the platelet, again, as the WBC, see the number, whether it is normal, decrease, or increase, and see whether the platelet morphology is going to be normal, and see the size, see the size of the platelet and see the platelet aggregation as in the previous question, whether the platelet are going to be get aggregate and not. Right, something has happened to the sharing of the.
Yes, Chandimai, can you share again, because
Right.
it came to me again.
Right. Okay. I think now it can see it again, no? Right.
Yes.
Right. Something is going to be happen there. The lot of drawings are there.
That's why I taken host, because I want to delete it.
Okay. Right. Okay. We move on to the next one. Right. This is the main investigation that we are going to be do in a hematology lab day-to-day work. We are doing the full blood count report. And then the next one, what we have to do, the reticulocyte count. Right. In a normal situation, with the Romanesque stain or the common one, Leishman stain, we can see the reticulocytes as the purple color cells or slightly purple color cells due to the RNA remnant present in the reticulocytes. Reticulocytes are going to be named as the mature cells. They are going to be appear in the polychromatic cells due to the RNA in the cytoplasm. But it cannot be differentiated, right? So it is somewhat difficult to differentiate the reticulocyte, but roughly you can say the patient is having higher number of reticulocytes in the patient circulation. But to differentiate that, we have to do a special stain known as supravital stain. The meaning of supravital stain means that we are going to be stain the living cells. We are going to stain the living cells using the supravital vital strain. There are a lot of supravital routes. There are a lot of supravital strains are going to be used. New methylene blue, brilliant preserve blue, but the appropriate one or the best one is the new methylene blue to stain the reticulocyte. The new methylene blue is this best one for the demonstration of reticulocyte count. What we are going to do there in the demonstration of reticulocyte count manually, we have the equal volume of blood along with the stain, equal volume of blood. But remember, if the patient is an anemic one, we have to increase the amount of blood. Suppose if you are going to add 1 drop of blood and 1 drop of stain in normal situation, you have to add 2 drops of blood and 1 drop of stain in an anemic patient. On the other hand, it is other in the polycythemic patient. If you are having the polycythemic patient blood, you have to add 1 drop of blood and 2 drops of stain. You have to increase the volume of stain and mix it well and allow to stand at 37 degrees about 20 to 30 minutes and draw film and observe the cells. Right? So you can see the reticular material or the remnants of the RNA in that red cell add pointed things and fragments in the cells. So what you have to do, you have to count the number of reticulocytes in, you have to count the number of reticulocytes present in among the red cells. Along with the red cell, you have to count the number of reticulocytes, right? While you are counting the red cells, you have to mark the amount of reticulocyte going to be present in among those red cells. Suppose you have to count, you are going to be count, right? In book says it has to be count at least 1000 RBC. You have to count at least 1000 RBC and you have to mark the amount of reticulocyte count, reticulocyte present in that 1000 RBC. Suppose you are going to be, you got about 200 reticulocytes in 1000 RBC. You got 200 reticulocytes in 1000 RBC. You have to calculate the percentage of reticulocytes. You have to calculate the percentage of reticulocytes, right? If it is going to be 200 in out of 1000, you have to multiply, you have to divide 200 by 1000 and multiply by 100. It's going to be 2%, no? Right? So we have to report the reticulocyte as a percentage. Normal percent is going to be 1.5 to 2 in normal healthy adult, right? The importance of this is, along with this reticulocyte count, we have to calculate absolute reticulocyte count. As earlier mentioned, absolute reticulocyte count means the total amount of reticulocyte present in 1 microliter of blood. So how it is going to be calculated? You calculate the percentage of the reticulocyte and you know the amount of RBC in the patient blood, right? In the full blood count, you know the amount of RBC in the patient blood, right? So multiply the percentage with the RBC count. If it is say 0.2%, if it is say 2%, if the RBC count is going to be 5 into 10 to the power 12 per microliter, you can calculate the absolute red cell count, absolute reticulocyte count. As well as there is a adjustment of the reticulocyte according to the patient PCVOHB, right? Adjustment of the reticulocyte count can be done according to the patient PCV or the HB. If the patient is anemic or if the patient is in low amount of PCV, we can adjust, right? What we are going to be do, we calculate the reticulocyte index. We calculate the reticulocyte index, right? How we can calculate the reticulocyte index? Divide the patient PCV OHB by normal PCUHB, right? At that point, we we take normal PCV as 45%. In the case of reticulocyte index calculation, we take the normal PCV as 45 and divide the patient PCV by 45 and multiply by the reticulocyte percentage. So it gives us the reticulocyte index. These are the two parameters with the help of reticulocyte count that we are going to be calculated. One is going to be named as absolute reticulocyte count. Other one is going to be named as the reticulocyte index. But in the later stage of the development of reticulocyte count, the fluorescent dye is going to be used to demonstrate the reticulocyte, right? It is very easy to identify the reticulocyte with the fluorescent dye. But the problem is, in the manual method, this fluorescent dye is going to be get faded quickly. This fluorescent dye or the fluorescent dye is going to be get faded quickly. Because of that, we have to do it immediately. Normally, acridine orange is going to be used as the choice of stain for the manual fluorescent reticulocyte count. But it has been got easier in now modern machine. They are using this fluorescent technology. They measure the reticulocyte count. Not only that, they are going to be differentiate the types, especially in the modern hematological analyzers. They are going to be differentiate the types of reticulocytes. There are 4 types of reticulocytes can be appear according to the appearance of the reticular remnants, right? From type 1 to type 4. So actually, I can't remember which one is type 1, which one is type 4. According to the distribution of the RNA from lesser 1 to higher grade, we can differentiate the presence of reticulocyte from type 1, type 2, type 3, and type 4. It is going to be done with the modern machine even now, right? According to the distribution of RNA remnants, they differentiate whether it is a type 1 reticulocyte or whether it is going to be a type 4 reticulocyte, right? Method. Normally, we use the EDT or capillary blood can be used. Oxalate and heparinoid blood are not going to be used. Oxalate interfere the staining, and heparin is going to be decrease the quality of the stain. If we are use the anticoagulate blood, we have to perform the test within 1 hour, right? If not, we have to refrigerate the blood at +4. But anyway, we have to perform this reticulocyte count as soon as possible. Never keep it for a day to calculate it on the next day, because these red cells can be get matured and the appearance of the reticular remnants can be disappeared, right? Because of that, you have to do it as soon as possible. It is recommended to do within 1 hour of the collection. If not, refrigerate at +4. Normally, it also has been done within 4 to 6 hours. If you have been refrigerated sample, do it within 4 to 6 hours, right? Right, the calculation which I have been mentioned, absolute reticulocyte count and reticulocyte index. And these are the appearance of the reticulocyte in the Romanesque stain or the Leishman stain. And this is the appearance of the reticulocytes. So these are reticular remnants, you know that. And this is a normal blood picture which is being stained, right? The same blood picture which has been stained with the new methylene blue, and the same patient sample which is stained with the Leishman stain, right? So here it is somewhat higher amount of reticulocytes are going to be there, right? In the counting, what we have to do, we have to count like this. The first one. This is also be going to be count as the red cell. 1, 2, 3, likewise. You have to count the red cell, right? Right. Any question regarding the reticulocyte count?
I have a question regarding
Yes,
this.
ask.
So in case of this is kind of hematological terminology, right? So
Yes.
in case of erythroid hyperplasia, so what
Erythroid
are
hyperplasia,
yes,
yes.
what would be the retic count? I mean, do you have any experience regarding the count percentage or index?
Right. Erythroid hyperplasia means the bone marrow is going to be produce higher number of erythrocytes again. Means they are going to be having the higher production of red cell. At that time, so I can't exactly say what can be happening in the reticulocyte, because if it is going to be an early stage, nothing is going to be with the reticulocyte count, right? But if it is going to be in the later stage of the erythroid hyperplasia, there may be higher number of reticulocytes. Why is that? Why is that? The patient is going to be having higher number of the production. Due to the demand, the production is going to be increased, but the supply is going to be get not much. Because of that, what is going to be happen? The more and more immature cells are going to be come onto the circulation. Because of that time, the patient may be having higher number of reticulocyte in the later stage of the erythroid hyperplasia, not in the early stage. Okay, right? Someone asked, can we use capillary blood? Yes, we can use the capillary blood, but your puncture should be proper, right? As well as you have to wipe off the first drop to avoid the contamination of the tissue fluid. We can use directly the drop of capillary blood, but puncture should be proper.
Another question.
Yes.
In case of infant and immature babies, right? So what would be the misleading? They may present NRBC even, right? Is there,
I didn't got your condition. In case of which condition?
this is kind of healthy, but I'm asking regarding infants and babies, right? So
Infants and babies. Okay.
yes, what are the misleading condition where we can't exactly say whether it is NRBC or reticulocyte? How would we, what would be the counting? Yes.
Right. So normally, in case of infants and children, it is clearly we can in NRBC and the reticulocyte can be clearly differentiated, right? So normally NRBC where it is having the nucleated cells, but in reticulocytes it is not having a nucleated cells. It is only having the remnants of likewise these remnants are going to be in the neoepithelial blue. If you see the Leishman stain here, see they are going to be as the polychromatic cells. Yes. Right? But if it is going to be NRBC, you can see a clear cytoplasm around the nucleus. It is not going to be look as a polychromatic cells. You can see a nucleus and a clear margin of cytoplasm, or maybe eccentric nucleus, as in late non-blast. It is a late non-blast. The nucleus is going to be get eccentric, and other side of the cell you can see clearly the cytoplasm. It can be clearly differentiated from the polychromatic cells and the NRB. Right?
So in case of supravital stain, what would be the nucleated RBC?
All right, they are going to be stained as then white cells. So even the white cells can be stained with this supravital stain. NRBC is going to be stained. Nucleus is going sorry, nucleus is going to be stained in deep purple color, deep blue color like this. It is clearly a nucleus is going to be stained.
Right,
but
thank you.
retic is going to be stained as filamentous or dot-like fragment.
Thank you. Right.
Excuse me, sir.
Yes.
My question is not regarding the reticulocyte count, but I want to know that you previously mentioned that low cell counts can be due to the hemodiluted sample.
Yes.
So it can also be due to the aspiration error of the analyzer.
Yes, definitely. Can
we differentiate those conditions by looking the
Yes, the first thing,
Manu.
right? So are you working with an analyzer? Are you
Currently,
working
I'm
with
not
an
working.
right, right. The first one, right? So this problem is not going to be so much, right? So at the first point, if your machine is a good one, they are going to be indicate the sample has been partially aspirated or incomplete aspiration, right? Sometimes they are going to be give the star marks in some values. It shows the sample is not aspirated properly, right? Or else even that all three cell lines drop parameters can be observed in the full blood. So it says the sample is not aspirated properly. Not only the aspiration, right? Sometime in your autoloader is not working properly to mix the sample. So there should be 3 to 6 time inversion before the aspiration of sample in your autoloader. If the autoloader is not working properly, this mixing is not going to be occur. At that time, what is going to be happen? Instead of the cells, they are going to be aspirate plasma, more and more plasma. That is a partial aspiration. At that time, the total cell line count is going to be get reduced. Look like pancytopenic. At that time, you have to observe the sample, see whether there is a clot. If not, draw blood film, see whether your report is going to be tally. If not, redo the test. Before asking a sample at that time, redo the test. And most of the time, in your second attempt, the report is going to be get correct.
Redo the test with the same sample.
With the same sample, before asking a new
Okay.
sample,
Okay.
right?
Okay. Thank you.
Right. Any questions? Right. The next one is the ESR, or erythrocyte sedimentation rate. This is a very simple, non-specific rate, non-specific test. In this one, what we have to do, we have to mount a blood sample and wait for 1 hour to see what is the rate of the cells are going to be falling down, or what is the rate of falling of red cells, right? So this is going to be named as erythrocyte sedimentation rate. This is not a non-specific test. Most of the time, this is going to be replaced with the C-reactive protein nowadays, because in each and every condition where the ESR is going to be get high, the CRP is going to be represent. But there is a important, see, CRP is having quick response regarding the elevation as well as in the responding to the treatment. As if I mention, ESR is going to be slowly elevated in an inflammatory condition, but CRP is going to be get high quickly in inflammatory condition. When you are going to be treated, the ESR is going to be come back to the normal status very slowly, but CRP is going to be get quick response, and CRP is going to be get reduced. C-reactive protein is going to be get reduced quickly to the treatment response, right? Because of that, this is going to be known as non-specific test, but still we are doing it, right? What we have to do, we have to mount the anticoagulated blood in a tube and wait for 1 hour and see what is the amount of cells has been sedimented. This sedimentation is going to be depend on 3 factors mainly. The first one, number and size of the red cell. Normally, if you know, අපි මොකක් කරේ එකක් දැම්මාම මේක පල්ලෙහාට බයින ස්පීඩ් එක මතක් රඳාපවතින තියෙන ප්‍රධාන සාධකය. If we see in general, the main one is the mass or the size of the cells. If the and the heavy of the cells, if it is going to be in the more heavy cells, it is going to be fastly move down. It means it is going to be increase the flow falling rate. Mass එක වැඩි නම් බර වැඩි නම් falling rate is going to be increased. But in the other hand, if it is fully packed with the cells, what is going to be happen? If the sample is going to be fully packed, again the falling rate is going to be get slow. Why? There are no space to fall. In in polycythemic condition, the patient is having higher number of cells. Now what has happened? The total cell, tube is going to be filled up with the cells. Because of that, though there are higher number of cells, no space to fall. Because of that, falling rate is going to be decreased. The first one is number and the size of the cells. The second one is the plasma factors such as fibrinogen and globulin. So what is the effect of this is, you know, the red cells are going to be negatively charged. Because of that, always the red cells are going to be apart. They are not going to be get attached to each other due to the negative charge of the red cell. This negative charge is due to the presence of membrane proteins in the red cells. But suppose a patient is in inflammatory condition, they are going to be produce different type of plasma protein, right? Different type of globulin and different type of fibrinogen, they are going to be produced. This affect the negative charge of the cells. Some cells are going to be lose their negative charge. Because of that, the cells are going to be attached. What is going to be happen if the cells are going to be get attached? The red cell mass is going to be get increased. If the cells are going to be get attached, the red cell mass is going to be increased. Because of that, in another way, we name it as the formation of rouleaus are there. Cell are going to be get filing up. Cell they are going to be get filing up, and the red cell mass is going to be get increased. Because of that, their polling rate is going to be increased. That's why in inflammatory conditions, higher ESR could be observed. Due to the presence of abnormal plasma protein, the red cell negative charge is going to be get diminished. Due to that, the red cell mass is going to be get higher due to the filing up of red cell or the formation of rouleau, and red cell mass is going to be increased, and the polling rate is going to be increased. The third factor is the certain technical and mechanical factors, you know, right? So sometime due to the heat, the ESR is going to be get increased, and sometime due to the angle of the tube, red cell may be ESR going to be increased. That this is a developed technique by the WHO. Apart from 1 hour, we can take the reading within 7 minutes in 45 degrees angle mounting of the ESR. In 45 degrees angle of the mountain by ESR, we can read within 7 minutes, right? As well as we have to mount the ESR away from the centrifugation and the direct sunlight, and those have to be avoided when you are mounting the ESR, right? Right. Someone, in modern machine, is it automatically mix the sample? Yes. In some modern machine, in autoloader, they mix the sample before aspirate the sample into the sampling probe. Right? Modern machine with autoloader, they load the sample before aspirate the sample. They mix the sample 3 to 6 times before the aspiration. Right. The main factor of the ESR is the amount of the red cell present. This will affect the size of the pollen particle, right? It increases the mass. The size of the pollen particle is dependent on the formation of the RBC aggregates. I told you why the RBC are going to be aggregates for the formation of rouleau due to the presence of abnormal plasma protein. Formation of the aggregates are dependent upon the amount of fibrinogen globulin present in the plasma. I have been describing, right? I described by RBC aggregate, the negative charge is going to be get disappear due to the presence of different type of plasma protein, right? There are two methods, Winthrop method and Westergren method. Most of the time we use the Westergren method. Here we use the 1:4 trisodium citrated blood. It may be either 3.2 or 3.8%. 1:4 ratio citrated blood has to be used in Westergren method. And in Winthrop method, we can use the EDTA blood. Even in the Westergaard method, you can use the EDTA blood, but before mount with the Westergaard tube, you have to dilute blood in 1:4 ratio. But in Winthrop method, you can directly use the EDTA blood, right? Right. So this is very important, right? Again, I must ask. I may told you that they are not going to be asked how we are going to mount ESR or the other things, but they may be asked from you. So what are the errors and precautions that you have to be done in the mount of ESR? So it can be changed due to the temperature. You have, because of that, you have to mount it away from the water bath and the direct sunlight. And clotted blood should not be used. That is one. If you are going to be used the clotted blood, the task is not going to be happen correctly. So here and there we can see the plasma column. It is going to give false result. Diluting with anticoagulant blood and mounting should be done properly. The dilution should be 1:4 with 3.2 trisodium citrate in Westergaard method, but not in the Winthrop method, right? Mounting should be in clearly vertical position, and in the flat area, the rack should be in the clearly flat area, should be placed the rack, right? Then tube should be clean and dry. It should not be contain any water droplets which may be cause the hemolysis, and there should not be protein. If the tubes are going to be have the protein, you have to deproteinize the tube before mounting the cells and breathe. Right. Someone is on is 45-degree angle method recommended. Yes, it is recommended by the WHO. If you go through the Daisy and Lewis practical hematology book, they clearly say it is a recommended one. But normal ranges has to be developed on own laboratory. They have to be developed their own normal ranges in that book. What is the minimum blood volume in 2 ml EDTA tube for automated analysis? What is the minimum blood volume in 2 ml EDTA tube for automated analysis? It depends on the type of tube. If it is a liquid one, you have to collect 2 ml, right? Right. If it is a pediatric one, it is not a problem. But if the tube say you have to collect 2 ml, you have to collect 2 ml. Why? If not, EDTA changes could be occur with the some, right? Most of the tubes now come with the EDTA coated one, but it has been coated for 2 ml of blood. Once we are mixing, if the EDTA is going to be getting increased, it can cause EDTA changes, shrinkage of cells and the fragmentation. Sometimes maybe the platelet aggregation can be occurred due to EDTA. Because of that, it is advised collect 2 ml, not lesser than 2 ml. But if you want to collect lesser than 2 ml, use pediatric tube.
Thank you, sir.
It should be mounted in absolute vertical position. Mounted stand should keep away from direct sunlight and vibration. These are the errors and precaution, right? It say normally do the test within 3 hours of collection of blood, but the last one is not going to be get counted much, but the book says like that, mount it 3 hours. Right, any question regarding the ESR?
So, in case of ESR, without citrated blood, we can use even EDTA blood. How do we prepare?
In which method? Westergaard or which method?
Westergaard method.
Right. Winthrop method we can use directly, but if you are using the Westergaard method, you have to dilute it 1:4. 1 part of trisodium citrate and 4 part of blood.
So in case of collection analysis, it should be worth to use for ESR.
Yes, no problem. You can use it.
Right.
Right. The last one which I have to discuss today is the osmotic fragility test. Right. What is going to be named as osmosis, right? So I just mentioned this one. What is the osmosis? Osmosis is the flowing of water molecules through a semipermeable membrane from a low concentration solution to the high concentration solution. In another way, water molecules are going to be moved from where the more amount of water molecules to the low amount of water molecules through a semi-permeable membrane, right? So when we are talking about the blood cells, the red cell is a semi-permeable membrane. Once we put a red cell in a solution, if it is isotonic one, isotonic means the concentration of the solution is going to be same as the red cell. Nothing will happen. The red cell is going to be acid. But if we are going to be put in a hypertonic means it is going to be having higher number of water molecules. What is going to be happen? Water molecules are going to be get into the red cells until the equilibrium is going to be achieved. මේ දෙකේම සමාන වෙනකන් water molecules are going to be get enter into the red cell. But if you are going to be put the red cell into the hypotonic one, water molecules are going to be come out from the red cells. In the first one, which I have been mentioned, where the hypertonic one, red cells are going to be again inflamed. They take the water molecules and get inflamed. And in one point, these cells are going to be get fragile. In one point, it is going to be get fragile. This is going to be named as osmotic fragility of red cell. This is going to be get named as osmotic fragility of red cell. Right? So what is we are going to be do? We prepare a series of sodium chloride solution and use large number of excess amount of solution and put small volume of blood into that solution. Prepare a series of sodium chloride solution and add equal volume of volume of blood, equal small volume of blood to the series of that sodium chloride solution. And allow it to stand at room temperature or 37 degrees centigrade for a certain time of period. Normally it is going to be 30 to 1 hour. And after that, centrifuge the sample and observe the hemolysis. And then you can calculate the percentage hemolysis by measuring the absorbance of the supernatant of this tube. And the tube which is having the highest number of hemolysis take as the 100% hemolysis. Normally the 12th tube we are going to be take as the 100% hemolysis and take the absorbance of that. Compare with that, calculate the percentage hemolysis of the others. And then plot a graph against the sodium chloride concentration, the percentage hemolysis. Plot a graph against the sodium chloride concentration of the percentage hemolysis, right? So in that situation, what we are going to do, we have to do a control along with the test. We have to do patient test along with the control. This control sample should be have from a person where in the same age, same sex, and non-relative person compared to the patient. Suppose the patient is 19 years old male, the control one also should be a 19 years old male. But the male person should not be a relation of the patient, right? 3 should be a must, right? So after that, plot the graph and compare whether the patient is having a higher fragility or fragility is going to be lower than the control. Whether the patient is having higher fragility or the patient is having a lower fragility than control. Suppose where I told you that there are a lot of types of cells, right? You know there are cells named as spirocytes, where the spirocytes are going to be having almost filled the cells with huge number of hemoglobin. There are no central pallor. It is going to be almost round. The cell is going to be round. It means it is fully packed. It means it cannot be intake lot of amount of water. It means the fragility of the spirocyte is going to be increased than the normal cell. Because it is going to be having lot of number of hemoglobin, it cannot absorb higher number of water molecules. Because of that, the fragility is going to be increased. On the other way, you know the cells named as sickle cells, where it has been shrink. It can take lot of number of සාමාන්‍ය red cell එකක් වෙනකනුත් වැඩි වතුර ප්‍රමාණයක් ගන්න පුළුවන්. After that, even it can absorb lot of number of water molecules. It means the fragility of the sickle cell is going to be lesser, right? So if you do a test and if you observe the fragility is going to be increased, it means most of the time the patient may be having spirocytes in the blood patient circulation, or the patient is having a disease related to the spirocytosis. If the fragility is going to be decreased, the patient is having the sickle cell or the microcytes. In that case, the patient may be having sickle cell anemia, thalassemia, iron deficiency anemia, likewise than BC. Right. If I say like this, if we do the test, and this is the principle and the chart, how we prepare the solution and the how we prepare the excess amount of sodium chloride solution, and we can report the 50% lysis. Normally we report the 50% lysis. It is named as median corpuscular fragility, MCF. In normal person, initial lysis is going to be okay in the 0.5 gram per deciliter of sodium chloride, complete at 0.3 gram per deciliter. MCF, again, 100 lysis lie in between 0.4 to 0.5, 0.4 to 0.45, right? So I think this is the tube where we mix the blood, and this is the tube where after the centrifugation. See, this is the normal one. Sorry, the first one is the normal one. This is the patient one, where in the low concentration of the high concentration of sodium chloride, cells are going to be get lysed. It means the patient is having higher fragility. The patient is having spirocytes in the blood, right? I think this is not going to be clear, but I just show you like this. This is the normal one, right? This is the normal curve, and these are the tests. All right. When we are going to this side, the sodium chloride concentration is going to be increased. It means here the low amount of water molecules are there. In this side, sodium chloride concentration is going to be increased. Higher number of water molecules are here. This is a hypotonic solution. This side is going to be hypertonic solution. If it is going to be shifted this side, it means the fragility is increased. It means what? The patient is having spirocytes. If the curve is going to be lie in the right side of the normal patient, the patient is having spirocytes in the circulation. If it's going to be lie in the left side of the normal curve, it says the patient is going to be with the microcytes, maybe iron deficiency or sickle cell or any other condition. With the other test, you have to confirm what is the patient, what is the disease that the patient is having. Right. In this one, what you have to remember, you have to use the excess amount of solution. And very important thing is you have to use a control. The control should be have the features which I have been mentioned earlier. It should be same as, same sex, and non-related one. Right. That is over. Any question regarding?
I have a question regarding this, right?
Yes.
So what are the factors which normally depends upon the osmotic fragility,
What are the factors?
which influence to osmotic fragility of the red blood cell?
Increase or decrease? You want?
Throughout, I mean,
Right.
increase. Yes.
If the fragility is going to be increased in the according to the shape of the cell, right? If it is a round cell, more prone to be having increased fragility. If it is going to be a shrink one, less prone to be having the fragility. And also the cellular constituents. If it is having more contents inside the cell, it has to be more prone to be lysis. Like fragility is going to be improved. But if it is going to be having less number of constituents in the cells, it is going to be having less fragility.
What about shape? Shape,
Sorry, shape.
Yes, shape. Okay.
Yes,
Volume.
right.
Volume.
Volume means total cell volume. It is not going to be a much factor because the volume is whether the volume is similar or lesser. It depends upon the shape and the cellular compound. Right? If it is a small cells, if it is having a less number of constituent, fragility is going to be decrease.
Surface area also.
Surface area can be a problem because if it is going to have a higher surface area, it can absorb more amount of water. No? At that time, the fragility can be decreased.
What would be the functional state of cells?
You mean whether the cell is function normally or abnormally, no?
Yeah.
If it is function normally, fragility is going to be get normal because we take the normal range into normal cells. But if it is going to be function abnormally and it is going to be produced more and more excess amount or the degradates, at that time the fragility is going to be increased because the cell is going to be filled up with lot of excess materials and almost filled up with other constituents rather than the water molecules, easily fragile.
So in case of specimen collection, what would be the specimen, ideal specimen?
Right. Normally we say the best one is the non-anticoagulated fresh blood. So if you can ask the patient to come on the day that you are going to be do the test and draw the blood sample at that point and add dropwise from the syringe or the pipette at that point without anticoagulant, right? It is the best one. But if you can use the EDTA blood also, but it should be a fresh sample, right? You can use EDTA blood also. It should be a fresh sample.
Rather using EDTA, what would be the what about the heparinized?
Heparinized blood
or
also
defibrinated blood?
Heparinized blood is better than the defibrinated.
Right. Thank you.
Right. What is the most suitable test for the spherocytosis, OFT or cryohemolysis? Definitely cryohemolysis. Not the OFT. OFT is not specific, cryohemolysis is membrane specific. Why I am saying that? In hereditary spherocytosis, there is a membrane defect. With the use of cryohemolysis, we detect the membrane defect, but osmotic fragility not may be only due to the membrane defect. It may be happen due to the different type of, right? This is regarding primarily regarding the membrane defects. Can we use citrated blood for patient having the platelet counts? Yes, we can use, but within half an hour, you have to aspirate it to the machine and you have to complete the estimation of citrated blood within half an hour. Maximum half an hour, heat up ready on the hour as soon as possible, do the test. It can correct the platelet clumps using the citrated blood. Any questions? Right. So I just put two questions, maybe important to write. So sometimes they may be asked a specimen of a boy of 11 years old who is admitted to the ward with fever and chill, show hemoglobin level is 9. So at that point, you can see the hemoglobin level is going to be low. You have to, it has to be come into your mind, the patient is having low amount of hemoglobin. So the question may be asked, what are the other basic hematological parameters that you want to observe on this child, right? Now you know what are the other parameters. HbA cardiovin, you want to know the BCE, NCA, NCH, NCH, C and the RDW. But do not stop from that phase. Write about the other two parameters, not only that, and the full blood count not only that, you have to observe the WBC count and the platelet count. Right. What is the next step that you want to take regarding the bulk specimen? What is the next step, Kivama? I put a slide earlier to you. You have to write all the things, observe the sample, and compare with the request form, and such things you have to do. And finally, you have to mention draw a blood film and observe the parameters. According to the size of the question, you can go beyond that. red cell according to the question and according to the marks given in the question, you can go beyond, right? And the last one, what are the steps that you want to take in issuing a quality report regarding the ESR test? The measurement of quality, you have to write that the things which I have been mentioned, the dilution factor, then the collection of blood, then the mounting of the ESR, cleanliness of the tube, and the timing, all things you can write, right? Okay, that's all. Any question? Right, if you have no question, we will wind up. And thank you for listening to me. And Dinesh, thank you very much.
Thank you, Chandramai, accepting our invitation. And we have another meeting. I will end up this part.
Recording stopped.